disease is the leading cause of death for women. So why is so much of the research centered on men? Most of it is. On today's All Things Heart, we discuss why decades of research on women and heart disease simply isn't there. Good morning, I'm Alexis Del Cid. Welcome back to Season 7 of All Things Heart, and just in time for American Heart Month. Because of that, I'm wearing red, and you're going to see a lot of red tomorrow as well for National Wear Red Day, not to mention the Chiefs being in the Super Bowl, so really, it's working out perfectly for all the red tomorrow. You know, most of us know a woman living with heart disease, whether it's your mom, your grandma, your sister, your friend. Right now, more than 60 million American women have heart disease. That's 44% of all women in the United States. A national survey on emergency room data shows women who report chest pain, which is the most common symptom of a heart attack, received a slower and less thorough initial evaluation than men. We asked a group of women for their take on women's health.
Women are crying out for help, and it's just the studies aren't there.
I don't want to get really worked up about this because I can. I would say emphatically that is the case. There were so many things that happened that I was completely unprepared for.
Medical research is done based on men and not women, and women are kind of disregarded as being different than men biologically and aren't maybe valued enough to put the resources to studying their unique medical situations, and so they miss out on stuff.
Older women are different, and so hopefully in the future we'll see more as researchers see the importance of women's health as well, and especially looking at age.
We get screwed because all the data is going for men. You know, men have a hard time, so they come up with Cialis and they come up with Viagra. And with women, they're like, well, if estrogen cream isn't going to help you, we just can't help you.
I have always been under the assumption that I could not benefit from hormone replacement therapy because my mom's had breast cancer twice, and I'm finding out that that might not actually be the case. So then I miss out on the potential upside, I think, particularly for cardiovascular benefits, and also maybe even arthritic problems, and who knows, a whole host of things.
Older women are often left out, and especially African American women. Researchers just need to wake up. They need to do more studies because not only with women, but also minorities, people of color.
I'd like to see more women specialize in maybe geriatric female issues. I would think that the more women in the field, the more help we're going to get.
I don't think until women become the CEOs of the major medical centers that you're going to start seeing the studies start being made.
We're here talking about the disparities when it comes to women and men, and it comes to heart disease. We have Dr. Hughes Thompson, who's going to be joining us. She's a cardiologist. Dr. Stephanie Windisch, who's a cardiologist. We have Dr. Hughes Thompson's mom, who's getting hooked up right now. And we have OBGYN, Dr. Carrie Winnicky. And in case you're wondering, well, what does OBGYN have to do with heart health? It has to do a lot with heart health. And we're here to connect all the dots for you and bring it all together. Dr. Winnicky, I want to start off with you because people don't associate often, I didn't until I started working here, hormone fluctuations, menopause, perimenopause, with risks in higher heart disease. What is it that hormones have to do with the heart?
Well, I mean, there's hormone receptors in almost all of our body. So there's heart, there's brain, there's fingernails, there's skin, you name it, there's hormone receptors. So anytime that we change hormones, all of those body systems have changes, and the heart is a perfect example. And we see this a lot in pregnancy, right? So it's like almost like the first test. I always say pregnancy is like the unmasker. So, you know, we can take a look at what your potentially risk factors are or health might be down the road during pregnancy. And so because of that, we can look at pregnant women and women that have problems with high blood pressure and cardiac issues in pregnancy. Really is a kind of almost an inside look into increased risk later in life.
That's so interesting, and we're going to dive deeper into that in a minute. We do have the rest of our panel seated, so I want to give proper introductions. We have Dr. Shannon Hughes-Thompson, who's an interventional cardiologist. We have Dr. Stephanie Windisch, also a cardiologist. And we have Dr. Shannon Hughes-Thompson's mom, Reese Hughes. We are so happy you're here. Reese, you are also an RN who's had extensive experience in ICUs and emergency departments, and now you're working to parlay that into teaching. So thank you all for being here. And thanks for rushing to make it happen, ladies. These women are champions. We have had the most hectic morning with parking, so we're really glad you're all here.
Thanks for having us.
I know. But we're really excited to kick off season 7 with all 4 of you. Dr. Hughes-Thompson, we're going to focus a lot of our discussion on the differences in care between men and women, but I would love to start with similarities in symptoms when it comes to heart attack symptoms. Can you talk a little bit about these as we show this graphic on the screen from the American Heart Association?
So it is chest pain, and I think a biggest difference between men and women is the descriptor and what they tie to their chest pain. You know, some people say, well, it presents different than women. It's still 70-80% it's chest pain, and how they describe it in the onset. And oh, by the way, their risk factors are the same. People who smoke, man, woman, black, white, whatever ethnic background you have, it's still diabetes, it's still high blood pressure, it's still obesity. So the risk factors are the same, and if anybody presents with those risk factors, they're talking about some sort of chest pain, and man, I'm not right. They get diaphoretic, shorter breath, they just know something's wrong. But again, the descriptor may be different, but the symptom is pretty similar, and the background to why that person would be someone to think really hard and to look for a heart attack sooner than later, that's the same.
When we talk about things like indigestion, fatigue, or pain or pressure, I often hear female patients who join the show talking about indigestion, and they just write it off as stress, right? Have you talked to women who are getting indigestion and then it turns out to be a heart issue?
So I have a lot of people come in and say, oh, it's my heart, and then when we dig deeper, it's like, well, no, it wasn't, it was something else. So the majority of chest pain actually, or any discomfort in your chest, let's call it that way, is actually non-cardiac. And so we always go to the heart first, or for the most part want to make sure the most serious things are looked at, and the things that would set you up for heart problems are addressed. Treat what you know. And then you want to dig deeper into what really is a driver. But I would say the situation that they present versus, say, in your clinic versus your emergency department urgent care, the risk changes because of the urgency they show up or how much it matters to them that they're having this symptom. And then, again, you go back to what's their heart rate, what's their blood pressure. You know, if you can get an ECG and you can get some background information on that person, you can usually dig through it pretty quick as what really is the driver and what you need to do to get them feeling better and make sure you're addressing things.
Dr. Windisch, when we talked at the top of the program about women arriving to emergency departments and they're not getting the same treatment as men, not here, but at other places, we're working really hard at the health system to make sure everybody gets the proper care. Why do you think symptoms aren't addressed as well in women as in men?
Yeah, well, like Dr. Hughes-Thompson said, chest pain is chest pain, but women, especially diabetic women, older women, may feel something a little bit different. Like you were mentioning, some nausea, some diaphoresis, maybe just anxiety and just not quite feeling right. And so when you come in with a description of chest pain, that's clear, slam dunk, let's do this. But if you come in with a vague symptom that's not totally really saying, oh my gosh, this is for sure a heart attack, then maybe the symptoms get kicked down the can a little bit, you do other workups, and some of that and some of the factors are women tend to ignore their symptoms. It's a generalization, but they'll say, oh, it's just my stomach, or oh, it's just stress, or whatever, and they may present later. Then
my mom does that a lot. In fact, she had AFib, and she won't mind me sharing this. She has signed a HIPAA, but she was writing it off as stress. Sorry, Mom. I know you're used to us sharing airing the laundry in the family, but she was attributing it to a lot of stress, which we are having as a family right now. My dad's ill, and it turns out she was in AFib, and she just thought it was stress or anxiety. So women do, I think it's okay. Yeah. Generalizations are there for a reason, and women tend to do that. Dr. Winicky, as an OBGYN, you often collaborate with cardiologists on this topic. Cardiovascular disease is the #1 killer of new moms, which is stunning to me to hear that number. It accounts for more than 1/3 of the deaths of new moms. How is it that the hormone fluctuations during pregnancy, and is it the hormone fluctuations that affect the heart?
Well, we do see, two different things really in pregnancy. One is hormones, but the second thing is we are making adaptations to support the growing fetus. So in order for a single person to support 2 different people, we see lots of changes in the heart and in the cardiovascular system. So not only heart, but blood vessels, all of those things that are associated with that. So, and as I mentioned sort of earlier, what we see is that some women don't have or have some problems with high blood pressure and things during pregnancy. And that's one of our biggest risk factors for cardiovascular disease down the road. So we've got great options, and we collaborate all the time. If we're talking specifically about pregnancy, we actually started a new cardiac pregnancy heart team here. So we collaborate specifically with cardiologists. Patients come in from all over the area and all throughout the Kansas and see both our maternal fetal medicine specialists and cardiologists and create really integrated plans to take care of these patients, because as our medicine progresses, people are living longer, and back in the day, a lot of these patients that have really complex diseases never thought about getting pregnant or didn't live to be pregnant. Right. And now we are. So we're really lucky to have such great colleagues here to be able to take care of these patients.
When it comes to perimenopause and menopause and postmenopause, something that I've learned from you as my OBGYN, let's just say that, is that the hormonal changes can impact your cardiovascular health. I'm pointing to my hip because that's where I have my estradiol patch that you have prescribed to me, but you have said that this hormone therapy I'm on can actually have protective benefits on the heart when you're entering menopause.
Yeah, so as I mentioned earlier, we know that estrogen receptors specifically and hormone receptors are really all throughout the body. And as we look at women that age, we certainly know that cardiac risks increase with age. Now, is that a factor of the risk factors that Dr. Thompson mentioned, along with hormones? And we've got some good observational studies that show the effect of hormones. But this comes back to your bigger question, is that we really don't have great evidence about if we give you back estrogen, what does that do? So comes back to your women and bias in medicine, right? Is that we just don't have these great studies. So what we talk about is well, observational studies, and we know this is what happens. And so we're and I tell my patients, unfortunately, I don't think in my lifetime I'm gonna have that evidence to share with you, because we don't have the money to put into these studies to really come with the outcomes that we wanna know.
Boy. That's frustrating to hear as a woman, or even as a guy who loves the women in his life. That's frustrating to hear if you're sitting at home wondering how women are being taken care of. I do want to give one woman on this panel some love. It's Reese. Reese Hoos, thank you so much for taking the time to join us. Did you know when your daughter became a cardiologist, she'd put you on TV?
No.
Now, you're also a nurse. You have extensive medical background. When you were coming up in training, was any of the talk of menopause, hormones, perimenopause in the heart discussed as much as it's being discussed now?
No, not at all. That's what I am so impressed with the OBGYN doctor here today. When I had my rotation in that in nursing school, it was all focused on babies. And nothing was really related to hormones at all, or ever discussed about when you went into menopause, how it could affect your overall health conditions. So I think it's very impressive that it's being aware of today, that there's education and awareness being brought to this subject in studies.
Absolutely.
I definitely did not know about that. I'm very blessed to have a daughter that is a cardiologist, because as I started to have some issues, I talked to her about it, and she explained that to me. and educated me on how it was probably my age and my hormones and of course all the things that go with that.
And what were some of the issues, if you don't mind sharing, that you were having that prompted you to talk to your daughter?
I started having, I noticed some shortness of breath, decreased energy. I developed high blood pressure. And I guess that's when I talked to my doctor or my daughter here. And
is your daughter your doctor?
Nah, well, she's my very good
Not officially.
consultation.
There was a certain point when she's telling me things like, you know, we don't get to ignore this.
Right.
And I absolutely, I don't want to be your doctor. I want to be your daughter who happens to know some medical things.
Yeah.
But dealing with her blood pressure is like, she's like, what's going on? You know, am I having a heart attack? What's going on? And you know, because she's a nurse, she lives thousands of miles away. She can get her blood pressure checked and let me know what's going on. It's like, yeah, we don't get to ignore this. We have to treat it now. And getting her initiated medical therapy, knowing, yes, you have to get that appointment. You need to, you know, make sure that you're taking care of this.
Yeah.
And so that's, she always thought
yeah.
she was healthy, and she was. She's very active.
Very
she
healthy
did not
and very active
do anything
and-
to set her up for it. And so to see her, you know, acknowledge that maybe I did know something that she didn't as a nurse.
Daughter might know something that mom didn't know. That never happens.
Well, it associated with it maybe in menopause.
Right.
And hormones, and that I totally did not associate that at all.
So even as a nurse, having been in medicine your whole adult life, even you didn't associate the hormones with the heart. I mean, that's such a shame that is what's happening, and that it's almost as if, and I see every woman on the panel nodding their head yes, does it feel like once women pass the age of being able to give birth, their health is just ignored? Dr. Hoos-Thompson?
I don't think it's ignored.
Right.
But again, back to the comment of how good is our evidence and understanding that we're not just saying things, you know. And I hate it when we use fear-based medicine, but again, like I'll give the example of some of the major trials that we really base our current guidelines for, say, high blood pressure, which is next to diabetes and smoking, is one of the biggest drivers to heart cardiovascular events, especially in women, is that the biggest trials only included about a third of women. And when you separated them out to say, okay, is the same benefit in women that we see in men? The answer is, no. But the overall trial looked good, so we're just going to do it for everybody. And the answer is, we're still kind of flying behind.
Right.
And we know women have more adverse events to certain medications or medicines and combinations, and how they respond to certain medicines were not quite as clear, and you just have to kind of work through that. And over time, you kind of start to understand a little bit better when you see these women. So it's difficult because it's blurry. Yeah,
Right.
we kind of know it's
Blurry.
out there and we start to see it, but it's not in focus as far as how we take care of women and how we integrate everything that needs to happen to do a good job.
Dr. Windisch, we cited a study off the top of the program that said women aren't treated as thoroughly in the ER as men. Have you heard that from your female patients once they make it to you from whatever hospital they've come from? Do they tell you they've had that experience?
Yeah, you know, a lot of my patients, and I know that focus is of older women, a lot of my patients are younger women.
Younger
and
women
they say
too.
the same thing.
Yeah.
They say, you know, either my symptoms were kind of brushed off, and I had to do a lot of research and a lot of self-advocacy. When women come to the ER and they come into the hospital, they oftentimes will say, you know, I was treated really well, but it maybe took a little bit longer. And again, that can come from them presenting a little bit differently or pushing off their symptoms. And what we know is that heart attacks affect men and women about the same amount, but women do worse with heart attacks. And it's typically
Interesting.
because of them either pushing off their symptoms or presenting later. And that's the sad fact.
Right.
And it's something that we all need to kind of be aware of. And that's why I think doing all these kind of advocacy things are
Absolutely,
really
which is why we're all wearing red today. In addition to the Chiefs, it's to raise awareness because it's American Heart Month, and specifically we want to address these disparities when it comes to women. We do have some great questions coming in. If you have a question for us, you can just send it to us on YouTube, Facebook, or the All Things Heart email. You will find all the links on how you can connect with us in real time right there on your screen. Reese, I have a question for you about awareness. My mom has said that when she went through perimenopause and menopause, nobody even talked about it. Specifically, I mean, obviously no one talked about the risk to the heart, but even talking about it, sharing openly that someone was in menopause wasn't a thing. Was that your experience?
Exactly. Yeah.
Boy, now it feels like everyone's just talking about it as if they have a You know, they're getting a haircut, they're in menopause, they're going for wine night. Like, everyone just talks about it, which is so nice. That must have been awful.
Yeah, it's totally overlooked, and I agree so much with the doctor when I did work in ER. When women came in with symptoms, they were really brushed off. Their symptoms were a little different than, you know, they had the fatigue, the weakness, the coloring, clamminess, and it was wrote off as the flu or something like that and brushed off. And I noticed as working in ICU, I recovered hearts for over 8 years after open heart surgery.
Wow.
And I noticed a difference in women's recovery versus men's. There definitely seemed to be a, I don't know, the women just had a little bit different recovery than men, slower. Maybe it was because their heart disease was more advanced before they had the procedure. I don't know. But
well, there are probably some differences we haven't yet even begun to scratch the surface on. Yes, we all have hearts, but men and women are different in a lot of ways, and so that might make it different in recovery. So we need more research to figure out why. Dr. Winicki, what questions should women be asking their OBGYNs when it comes to protecting their hearts, and when should they ask those questions?
Well, I think there's lots of different opportunities to ask the questions. The first of which I think we talked a little bit on is that if you're someone that in pregnancy that had preeclampsia or really any hypertensive disorder, you probably should be bringing that up to all of your doctors, your internal medicine doctor. Sometimes you don't always see an OBGYN, and that really is a great sort of, like I said, insight into potential increased risk factors down the road. So just bringing it up, I think, is an important part. And then I think that, you know, don't be afraid to bring these questions up. I hear all stories, you know, because the people that are going through menopause now, really it's their mothers that were silenced and suffered. And so they think that they were told for years that this is normal aging, this is what you should do, there is no treatment for this. And don't be afraid to bring it up, I think is the biggest thing. There are a lot of, you know, typically we just start out with just symptom, a long list, and we have to be really clear, like, oh, some of that might be, some of this isn't, we need to go to a cardiologist, or you need to go to your gastroenterologist. But don't be afraid to bring those things up.
I love that, and that's so on point. Dr. Windisch, do you have any theories? I know you don't have all the answers. You're not a wizard.
Sure?
I wish you did. We wouldn't be in this predicament. But any theories on why so little of the research has been centered around women when it comes to women's hearts?
Well, if you kind of look back at the history of cardiology and the history of medicine, they started really with, you know, the army, the military, and then it got a little bit more focused on these groups. And if you look back at those trials, like Dr. Thompson mentioned, it was really like 25 to 30% of our major landmark trials that we still base most of what we do in cardiology on were men. And so now there's laws that say that trials have to be equitable in terms of gender, but as she again mentioned, then they don't necessarily know why. We know that this trial works, but we don't know why it works. Is it working for 50% of men and 0% of women? They don't really necessarily dive that deeply into it. So just because the numbers are there, it doesn't mean that we're looking at it specifically for men versus women.
Dr. Thompson, Dr. Windisch touched on this a little bit. Does the FDA require a certain percentage of study participants be women or a certain gender or ethnicity?
It's not a percentage, it's just that. Around 1980, maybe give me a 5-year range of that, so late 70s, around at 1980. In order for a medicine or treatment to be approved by the FDA, if it was going to be used in a certain gender or ethnic group, then they had to be included in the studies that were considered before they were supposed to apply it to those groups, at least per FDA regulation. But again, it didn't say anything about, well, it has to be 50% of women, 50% of men. And so currently we kind of got hit a standard of about that 30 to about a third of patients, where we know that half the population is absolutely women. And we know that women suffer just as many cardiovascular events because they have high blood pressure, diabetes. And I think women more than men, actually, it's kind of shown that smoking actually affects women worse than it's affected men. And so we get some foundational information there, but it's a broad stroke. We can't really refine it to women and really. And again, back to what I stated earlier, yeah, women do present, and usually when you start them on a therapy at the same dose you would start a man, they come back and say, man, this is, whoa, you know, what'd you do to me? I don't know if it's worth having a stroke, if I'm going to feel this way taking this medication.
It's a man's dose.
So the combinations of doses, you know, we know there's probably some good benefit there, but as far as the details and kind of weeding through it, that's where it gets really muddled and a lot more difficult.
And details matter in medicine.
Social media times, you know, like, screw it, doc, I'm going to go look it up myself. And
oh boy.
Here we go.
Yeah.
And so, or they start kind of wanting to adjust things themselves.
Right,
you know?
which can be risky.
Yeah, and two, you know, women present differently. You know, a lot of times if a man's not doing well, his wife's sitting there right next to him, or his sibling or his child is there with him. A lot of times women, it's you know, they don't have their husband always coming. I see a lot more kids.
Right.
Ironically, the next generation is saying, hey, Mom, we got to take care of you. You know, we're going to the doctor and I'm coming too.
Yeah.
And making sure somebody's paying attention, or maybe it is their sibling who has had similar experiences, but I don't necessarily the same support within the family always coming through, but that's becoming better.
I think that everybody's going to really love this comment from one of our viewers. As we go to some of the questions and comments from our viewers, I love this because it's a very thoughtful comment from a man who's very concerned about the women in his life and how to better take care of them. And he writes, anecdotally, this is Jeremy Yenser, anecdotally, I feel like it's more common for the women in my life to come home from the doctor feeling like they were almost gaslit. A lot of, are you sure that's what you're feeling? Or that's not what you're feeling? Or it's probably just PCOS, that's polycystic ovary syndrome, right? It's just anxiety, it'll pass. So he's rattling off all the things that the women in his life have been told when they've gone to the doctor about something wrong. He wants to know, how do we help the women in our lives advocate for themselves if they feel like they've hit a wall getting help? You know, what's a man sitting at home watching this program to do to help the woman, his wife or his daughter? Dr. Winicky, any advice?
Well, actually, ironically, yesterday I was just seeing a patient, and the symptoms that she was telling me, my light bulb's going on, and she was told that she had been given an anxiolytic, an antidepressant, and a sleeping aid.
What's an anxiolytic?
Like Xanax or Valium.
Okay.
And I was like, okay, but I think it's not that. I think let's you know.
Wow.
So it's just shocking, and this is about education and awareness. I mean, the words weren't ever spoken for years, right? Because we were, man, that was just going to kill you. But I think, you know, back to your question, is just advocate to find someone that you feel that listens to you. And again, it's not always, you know, you shouldn't find someone that's going to just hand out medicines like candy, but someone that you think listens to you and gives you the information. So, you know, my talk is that I trust women, and I think women are really amazing individuals. So you have the power to listen to what I'm going to tell you and make your own decisions.
Right.
So I feel like in the past, perhaps women were thought like, just tell them what to do. They can't take the information that we know. They can't make their own decisions. But women are really amazing individuals. And
right.
we should trust
Yes,
them.
we are.
We just
amazing
need to give
individuals.
we need to give them the information.
Yes,
and then they can, through shared decision, really think about what that means for them. And everyone's different too, you know? I mean, you give them some risks and things, they're like, hey, thanks, that was really great information, but I don't think I'm gonna do that. Great, perfect, but that was like a discussion, right? Not just like, oh, fine, you're fine, you know, go home and sleep more.
Dr. Windisch, Rachel wants to know, how are the doctors on the panel fighting this battle when it comes to gender disparities? So are there specific things you do? Do you have a different awareness when you walk into your job every day?
Well, I think you probably can, all your patients are women. I'm going to generalize on that again too. But women tend to want women cardiologists, I think generally, because we listen a little bit better, and there's studies that have shown in the past that people do better when they have female practitioners taking care of them. But I think that the American Heart Association, the ACC, is all doing a lot of advocacy and a lot of education. And so in general, I think that making the education out there, making the information available, and then really working with women and making ourselves available to answer questions is kind of how, as a team, we should all help take care of women, raise us all up.
I agree. Jamie has a question. I'm going to send this one to Dr. Hoos Thompson because it involves Reese. In an offhand way. No, Jamie wants to know, she writes, this topic really hit home because my mom downplays her symptoms. How can I convince my mom to not downplay her symptoms and to go to the doctor? Did you feel like your mom was downplaying her symptoms? And then I'll let you speak for yourself, Reese.
So, you know, women who achieve a certain level of independence do feel like, hey, it's better if I just take care of it myself. Or because of what I know and have experienced in what other way, I'm going to be okay, or just say, I'm fine, I'll work through it, like I have so many other things that come up in a frantic morning or whatever.
Yeah, you're juggling 10 plates. Yeah.
And so to hear her, and again, I try more to be her daughter than her doctor, but there is a point when she has to say it. She has to. At some point, you have to speak up for yourself. Like it or not, it's nice to have help and to have a system and support to get through that, and you need that. But that's one thing too, is to acknowledge, I can't do this by myself. I do have to speak to my family. I do have to talk to my doctor. There's a point where you can't be just all on your own when you face these things, and so that I think becomes really point to all these questions we're starting to field. And when you talk about health and especially Heart Disease Awareness Month, February, is about awareness, because we know 70 to even 80% of cardiovascular disease and events are really better managed by how you take care of yourself. So if you can't take care of yourself, there's no way you're going to take care of somebody else, and you've got to take care of each other. Tomorrow is the Red Desk Go Red for Women Day, which we've now been doing for over a decade, and I'm not sure, at least the information's out there, but it is dedicated to women in heart disease, because damn it, without women, we're not going to move forward in a positive way.
Right.
And that really does self-care first. Yes, get a support system.
Yeah.
You can't do it all by yourself, and I think women, believe it or not, take things on more by themselves, and until they're really in deep trouble, do they really look up and say, "Hey, I'm down here."
It's kind of.
And then you're, the battle out again. We're flying a little bit blind, and when you have to go that deep to get them out, it's still a little bit frustrating, and it is scary, but don't be afraid.
I mean, what I hear you saying also is that the cross Reese has to bear as being amazing and smart and independent, and then it also might inadvertently lead to not reaching out for help, because you've done so much and you're continuing to do so much. For our final thoughts, I wish we could talk about this topic for another 5 hours, although I know you have things to do today, so it won't keep you captive. But for our final thoughts, Reese, I do want to start with you. When you compare where we are now to where we were decades ago, when you were a little girl, when you were going through medicine as a nurse, what would you like to teach your students as you parlay into teaching in the future about women's health care?
Well, it's improved tremendously. Continue with awareness and education, but I think we're also blessed, nothing against male physicians, but I think we're so blessed that there's more female physicians, because I totally believe women feel more comfortable talking to a female about their health in any aspect than they do a man. It's just that they just have that ease. Not anything against male doctors, because I know many.
Right.
But I think it's just the education today, the awareness, like making tomorrow a Heart Association for Women awareness. We just got to continue. And start early, and include this in college. Start making this a part of the curriculum.
Right.
In OBGYN, in med-surg and all that, how all the women have these changes and things to watch for, and that they do die from heart disease as well. So.
Yeah, it all ties back to the heart.
Right.
We talk about awareness being critical to change. Dr. Winicki, what's the one thing you would like viewers to take away from this program?
So I think that, to me, it's just the amazingness that we're sitting here talking about it, right? This would not have happened 5 or 6 years ago, especially with 5 women. And I think that that's the thing to take home, is that we are at a really great time of which we see more women in medicine, more women out talking about this, and just the openness to talk about these things. As you mentioned, people wouldn't bring this up and talk about it. So the take home is, don't be afraid to talk about it, don't be afraid to share, don't be afraid to talk to your physicians about it.
Dr. Windisch, what was the one thing you would want our viewers to take away?
Yeah, I think, as we've been kind of talking, the most important thing I think in any healthcare situation is to know your body, take care of your body, advocate for yourself, and find a team of people that you trust and that are going to take care of you well. Your doctors, your family, all those things. And really, you got to take care of yourself so we can help take care of you.
Dr. Thompson, bring us home.
I'm with you. Yeah. So. Yeah, stay with it. It's not black and white. It's not easy. But again, it takes a team, and it takes everybody to recognize it in order to really move it in a positive direction. And can we do that? The answer is yes. And I think a lot of people, everybody, men, women, you name it, can really see a benefit. And this is definitely a place where, because we have that gap, we can really see an impressive upstart. So stick with it, and we'll be fine. We're going to do well.
Well, I know we're really honored to have 4 powerful, brilliant women on the set today talking about such an important topic. So thank you for taking the time to join us this morning. We really appreciate it. And thank you to our viewers as well for joining the conversation. If you would like to watch or share any of our episodes that have aired in the past, just scan the QR code on your screen. That will take you to links of all of our past shows to share and watch as you like. Coming up next week on All Things Heart, we're doing a whole week of heart stories for Valentine's Day. We're doing a week of love stories. And on Thursday, we share the love that these 2 patients have for their heart donors and their donors' families. Oh, and by the way, one of these heart recipients just received a very surprising letter in the mail. That's next Thursday at 8 a.m.
Coming up Friday on the Morning Medical Update. From the halls of the health system and across Chiefs Kingdom, it is time to cheer on for a three-peat. I'm Jessica Lovell. On a Super Red Friday edition of the Morning Medical Update, we talk with the doctors caring for both the Chiefs and everyday athletes. Friday at 8.